Good morning. I am Dr. Maria Alejandra Piñero de Plaza, and I am happy to be here to talk about telehealth as a new model of care for homebound populations. So first, I would like to acknowledge that we are meeting today, and I am presenting from the land of the Ghana people. So I pay my respects to the elders past, present, and emerging generations and leadership. Well, again, thank you for inviting me. I would like to give some background about why I'm here, why I do this work. So I have been working with Penelope and other advocates and consumers since 2017. We, in fact, were advocating for better consumer engagement with health research. And since 2019, I have been part of Professor Alison Kitsen's team at Flinders University. We are developing a new theory, an emergent theory called the care in life course theory. And the point is to emphasize the care is central to growth, to development, to health, to well-being, from birth to death. So care is not just an action, an activity that a nurse or a clinician or a mother or father does. It is a complex and evolving system, an interaction of systems and requirements shaped by life changes, our environments, and our personal characteristics. So in that team, within the Care Life Course Theory team, I lead the care networks and the evaluation aspects around the Care Life Course Theory and fundamental care, investigating and measuring its constructs, like fundamental care, care networks, and other 14 constructs, and the interconnectedness of these relationships, these networks within systems. So my research highlights that care is embedded, like I said, within personal relationships and professional settings, technological tools, and communities. So collaborating as well in this process of co-research with Penelope and her extended consumer networks, we created and developed a model and a framework called Proliferate. The framework is an advanced tool that can be applied to co-design, evaluate, assess, and improve intervention, technology, processes, and products. So potentially, we would like to use it in the future to co-design with different consumers solutions like telehealth, or like we are doing at the moment, investigate the implementation and integration of artificial intelligence within our health system. So basically, my priorities are in this process, inclusivity, focusing on how the social determinants of health and in general the socio-demographic characteristics and experiences that we have shape our behaviors and the care and the needs that we have. So through this investigation and the operationalization of the Care in Life Course Theory, I aim to ensure that care and care systems evolve in a fair way to meet the unique needs of individuals, groups, communities across diverse structures and systems. So to understand this topic, we have to define first the concept of homebound. Homebound individuals are those that are unable to leave their homes due to physical, cognitive, or social reasons, and they could be frail, bedridden, or living for a long-term period within their house, normally more than 6 months because of their chronic conditions, and the majority of them in the studies that we have done involve people living with ME/CFS. So our research group created the concept of the frail, homebound, and bedridden people to aggregate the different segments of the population that face significant barriers to accessing healthcare and GP services. We found that in 2018, about 600,000 Australians did not leave their homes as often as they would like to because of health reasons. So many of them relied on family caregivers, informal support networks, and these circumstances frequently led to their marginalization from formal health and socioeconomic systems. So after identifying and specifically which were the gaps that these populations were facing in terms of marginalization from health services, we disseminated these findings in reports, videos, book chapters, conferences, and events. Our goal was to raise awareness about the challenges faced by frail, homebound, and bedridden people, underscoring the importance that technology has within this context to bridge these gaps that we identify together. So by then, this started by the end of 2019 and 2020. So the pandemic of the COVID-19 was exacerbated and there were many uncertainties, but the pandemic highlighted the urgent need and as well the feasibility of technological solutions to provide support and better care for frail, homebound, and bedridden people. So the impact of our awareness work have been huge, and after dissemination and advocacy, some organizations nationally as well as internationally, but the one that I'm referring to are nationally, have further explored and documented the barriers for accessing care, especially around frail, homebound, and bedridden people, or what most people call homebound people. These barriers were clearly summarized in a white paper co-developed with and by many of the advocates from our frail, homebound, and bedridden people community. So our work coincides with the barriers identified in the white paper from the BHA in Brisbane South. We also saw workforce barriers, funding and policy barriers, equipment and resources barriers, models of care at different levels of the system and the health system barriers, and of course technology connected barriers. But in our publications and papers, we actually involve different experts from several areas, clinicians, psychologists, community members, social and health researchers of all sorts, to also co-create and provide and disseminate our solutions in creative ways so that they can reach different targets and audiences to promote action in this sense. So we created a free-to-access, print and download socio-scientific exhibition with videos and posters about the frail, homebound, and bedridden people experience, the problems associated with that experience, but importantly, we provided solutions, what solutions we see feasible for these populations. So we also did a book chapter on these participatory and artistic methods that we utilize for generating awareness, which is accepted for publication, but it's not publicly available yet. But in that book chapter, we identified 6 potential areas to address to support frail, homebound, and bedridden people in overcoming all the challenges identified. So the first one was education for health practitioners and all service providers about frail, homebound, and bedridden people needs. This will facilitate the creation of more inclusive and accessible communities and associated access to the physical environment, including public transport, parks, buildings, housing, digital information and communication technologies, and inclusion in civic life, including social, supporting, and recreational and cultural activities. The second was access to legal services that could support and protect the rights of frail, homebound, and bedridden people. They demand justice and a better legislation. For example, statutory protections like anti-discrimination measures, complaints mechanisms, advocacy, and better access to justice system were identified as relevant for the frail, homebound, and bedridden people. The third request is access to community care and rebates. This means providing better economic security, facilitating, when possible, jobs, better business opportunities, financial independence, and creating better possibilities so the frail, homebound, and bedridden people can receive adequate income support and/or housing. The fourth was social prescription by technology, which refers to personal and communication support concerning inclusion and participation in the community, person-centered care supported and provided by specialists and people with knowledge of disability services and mainstream services, informal care, and obviously support. Then in the fifth one is telehealth and virtual care, basically the topic that we are discussing today. So health and well-being require providing online health services, health promotion, better integration between health and disability systems to increase the frail, homebound, and bedridden people experience overall, their well-being, and their enjoyment of life. And the last one is about implementing these technological solutions in different shapes and forms, apps, online platforms, robots. We have communicated with homebound people, actually living with MECFS. They created small robots that allow them to visit parents, stay in important family events without leaving their home. So this means we increase the opportunity for learning, for acquiring skills, to embrace early childhood education, because as you know, many homebound people, actually the majority, according to the 2018 survey, are younger than 65 years old. So support these people with these technologies across the lifespan. So these technologies can increase their participation in schools, education, vocational activities, and transition from education to employment. And according to their characteristics and needs, that we know they are different from people that are not homebound. They can also facilitate lifelong caring services. So through the years, we have been evolving in the kind of feedback that we can provide in our collaborative research program. So currently, we have under review an extensive systematic literature review and meta-analysis of all quantitative studies, clinical trials, and experimental investigations to provide evidence around telehealth as a model of care. So since this work has not been accepted yet because it's under review, I will only disclose that from 3,289 articles that we review across the whole world, all the studies across all times, our meta-analysis revealed that telehealth interventions significantly reduce healthcare utilization, enhance health-related quality of life, and improve well-being compared to in-person care. So this meta-analysis included 3,289 articles and 2,245 participants. So then we can now say that telehealth is emerging as a viable alternative to conventional care because it significantly reduces healthcare utilization and enhance both quality of life and well-being for homebound populations. So these findings underscore the potential of telehealth to mitigate healthcare disparities and emphasize the need for accessible, equitable telehealth services co-develop with end users and relevant stakeholders to save resources and maximize health outcomes for vulnerable populations living in the community, like the cases of frail, homebound, and bedridden people. So at this point in time, for us, the future involves co-designing, funding, and implementing these telehealth services. So the white paper that I mentioned previously from Brisbane South, the PHN, it indicates that fixed and temporary homebound patients do not typically classify for Medicare services or items or exemptions because of their homebound status. So this is predominantly attributable to the difficulty in defining the homebound population and a lack of established eligibility criteria for those subpopulations who will qualify as fixed or temporary homebound persons. So the introduction of an additional item or exceptions to existing items to provide primary care accessibility requires that the criteria to classify an individual as homebound be established at a national level. Therefore, the concept and epidemiology of frail, homebound, and bedridden people should be investigated further. We need evidence and more advocacy to support and define homeboundness based on an aggregation of sociodemographic, experiential, and health factors, avoiding establishing accessibility support based only on the population's most symptomatic diseases. In conclusion, across this presentation, I have shown that we have identified the frail, homebound, and bedridden people require a new model of care. We have established the barriers around that, and we are providing scientific evidence to support telehealth utilization instead of in-person physical attendance. The next steps require science-based political action to collect national data that will help us measure the right parameters to define a fair homeboundness criteria to implement this model of care. So thank you so much for listening to my presentation, and I'll be here to respond to any questions that you might have.